Hello friends, and welcome back to the channel. I hope that everybody is doing well. Whether you're in school right now or you are practicing, hopefully it's going well and life has been good to you. If you are new here, then hello, my name is Brittany and I am a family nurse practitioner currently working in an urgent care, and I make content for nurse practitioner students and nurse practitioners currently in practice. I love to learn, I love to teach, and so that passion is what started this channel. I also love connecting with other people, and this community has been a wonderful way to do so. So anyways, for today's video, I'm going to be discussing managing common orthopedic injuries in the outpatient setting. As I already mentioned, I'm currently working in an urgent care, and orthopedic complaints are a very large component of the patient population that we see there. So if you're going to work in an urgent care setting, then I definitely recommend that you build on your orthopedic skills. But even if you're not, this topic is very relevant for your board's exam and in primary care as well. And so I think it's just a really important topic overall to discuss and improve our knowledge on. So the video, like I said, will focus on the most commonly seen orthopedic fractures in the outpatient setting, and it will be in regards to the adult patient specifically. Perhaps I will do a part 2 in the future where I discuss the pediatric population perhaps more in depth, or sprains. There's some other ideas that I want to further elaborate on, but for today's video, we will be focusing on only the adult population and the most common orthopedic injuries that you will see. So before I get into it, these are the injuries that I will be discussing, and in the following order. So as you can see, first we will talk a little bit about general principles in regards to orthopedic injuries and a little bit about orthopedic lingo or language. Learning the language can be half the battle sometimes, I feel like. And then we will just jump right into injuries. So first I will discuss nursemaid's elbow or radial head subluxation. Then I'll go into distal radius and ulna fractures, metacarpal fractures, phalanx fractures, distal tibia and fibula fractures, and then finally metatarsal and phalanx fractures of the foot. Of course, there's many more injuries that can occur, but these have been the most common fractures that I have seen working in the urgent care, and so I think this is a really great place to start. All right, so orthopedic principles. These are some really important key principles when managing an orthopedic injury in the outpatient setting. First, always palpate and examine the joint above and below the site of injury. This is just really good practice, and it will help prevent you from missing any additional fractures or injuries. Next, one view is no view. You might have heard this saying before. I did not come up with this. This is a common saying in the orthopedic world. One view is no view. 2 orthogonal views is the minimum amount of views that should be done when examining a fracture. There are actually 2 x-ray images and a couple slides coming up that kind of show multiple views of the same fracture, and I think it's just a good example of how much information you can get from looking at additional views. So next up, the next point here is when in doubt, splint. So if you are unsure if there is a fracture, then it is safer to assume a fracture is present and splint it appropriately. So based on lots of evidence, immobilization with splinting is a benefit in the vast majority of cases. So basically it's better to err on the side of caution. Splinting is the preferred method as this allows for swelling to occur, and thus it helps to prevent neurovascular injury. It also helps to prevent fracture displacement or the loss of a reduction if that was done in the office, and it protects the area from further injury, and it helps also to improve pain for the patient. After splinting, instruct the patient to follow up for repeat x-rays. If it's indicated, as many hidden fractures can become apparent by then. So the next principle is to splint it where it lies. So splint the injury where it lies. So the only exception to this rule is if the patient is not neurovascularly intact distal to the injury. If this is the case, then immediate reduction should occur, of course, and then this new reduced position should then be the splinted position. If the practitioner is unable to successfully reduce the patient, then the injury should be splinted in the least neurovascularly compromising position possible, and the patient should be referred to the emergency department for reduction. After splinting, a patient should be instructed to seek immediate medical attention if they experience pain that is severe or worsening, numbness that is new or increasing, skin discoloration distal to the splintness. All of this can be evidence of a neurovascular compromise. And then finally at the bottom, here are indications for a referral to the emergency room, and those include open fractures or extensive tissue injury, tendon injury, neurologic or vascular compromise, and then lastly, acute compartment syndrome. And symptoms of compartment syndrome, if you remember this from way back in school days, unless I guess you're still in school, but those include disproportionate pain, pallor, paresthesis, and tense swelling. So this slide goes over terms used when describing a fracture identified on an x-ray. As far as interpreting orthopedic x-rays, it's something that just takes a lot of practice. Every x-ray that you can, I recommend that you look at it and study it. I recommend that you become familiar with interpreting them and just also making a habit of looking at normal x-rays as well. If you are unsure of what you are looking at, and whether or not it's normal, then what I always do is I pull up a normal x-ray on my phone and I simply compare the one to the patient. Also, getting bilateral views can really help you with this as well. If you are unsure, then you can get a comparison view of the other, whatever it is that you're x-raying. So for example, getting bilateral wrist x-rays if you wanted to compare the images. Other than that, this video is not really discussing how to interpret x-rays. It's more about how to manage fractures found on x-rays. If you would want to hear more about interpreting orthopedic x-rays, then I could maybe do another video on that. Just let me know in the comments down below. But in the text box here, it shows that different features help to classify a fracture. So for example, identifying the bone or bones that are involved, the location of the fracture on the bone that is affected, the orientation of the fracture itself, whether it is open or a closed fracture, and then whether or not the bone is displaced or also known as out of alignment. These are very useful images here depicting the characteristics that I just went over. I really recommend looking over these and becoming familiar with the terminology, as this is going to be a huge benefit to you, not only when identifying fractures, but then also for documentation purposes as well. The first orthopedic injury that I'm going to discuss is radial head subluxation, also known as nursemaid's elbow. This is the only injury that is not a fracture in the video for today, but I decided to start with this as I've seen this already a handful of times in the urgent care that I'm working at, and initially I was a little intimidated by this. However, it's really quite simple to manage once you know what it is that you're doing, which makes sense, obviously. So the diagnosis of nursemaid's elbow, it can be done based on physical exam and history alone. If the injury occurred from pulling on the affected arm in a child who is 5 years old or less, and this is because strengthening of the annular ligament, it occurs by 5 years old, and thus this significantly decreases the likelihood of injury from occurring once they are above that age. On exam, the child with radial head subluxation, they often will hold their affected arm near the body with the elbow slightly flexed or extended, and then the forearm pronated. Physical exam should confirm that there is no focal bony tenderness, ecchymosis, deformity, or swelling, as this can of course indicate a fracture, and in those circumstances, x-rays are recommended. So once you've confirmed that radial head subluxation is a diagnosis based on both physical exam and your HPI, reduction can be safely done in the office. So there are two methods listed here, hyperpronation and then supination and flexion. The one that I was taught was actually supination and flexion, and thus far that is the method that I have done. However, after more research, UpToDate actually recommends that hyperpronation is the preferred method, as this technique has had, I guess, higher success rates and it's potentially less painful for the patient. So I personally have not had difficulty with the supination and flexion method, but knowing this now, going forward, I will definitely try and use this hyperpronation technique. There are some really great videos on YouTube available where you can actually watch this being done on an actual patient, so I really recommend watching those, and you can really kind of see how easy the technique is. But for the hyperpronation technique, the practitioner applies pressure on the radial head with their non-dominant hand, and then with the dominant hand grips the patient's distal forearm and hyperpronates. And so a click might be felt, or it could be heard by the practitioner, and the patient should experience significant pain relief and then regain function of the affected arm. And typically this happens almost immediately. However, according to literature, if you did this correctly, they should regain function within 15 minutes of reduction. And then to confirm that the radius is actually back into place, then you should have the child reach with the affected arm for something enticing, whether it be a toy or a popsicle, but something that will entice them to go ahead and extend the arm that you just reduced. And then if radial head subluxation or nursemaid elbow it is successfully reduced, then it's not necessary to splint this patient or put them on any activity restrictions. They're able to go about and return to their normal daily activities. It is, however, important to go ahead and educate the caregivers on how to try and avoid these injuries from happening again in the future. So before I talk about wrist and hand injuries, I included these images of both the wrist and hand anatomy. It's really helpful to have an idea of the general anatomy and, like I said, what a normal x-ray looks like. And so you can see here how the phalanx are divided into proximal, middle, and distal, and then the carpals and the bones that comprise the wrist, including both the distal radius and the ulna, and these areas are very prone to injury. Specifically, the distal radius, this is the most common fracture site of the upper extremities, and it's often caused from a fouche injury or falling on an outstretched hand. And we'll kind of go into that a little bit further in the next slide. All right, so a distal radius fracture, like I said, it is the most common fracture site of the upper extremities. And like I also previously mentioned, it's often caused by a fouche injury or falling on outstretched hand. Fractures that are non-displaced and not involving the joint, these are generally stable, non-surgical, and treatment simply consists of splinting and an orthopedic follow-up to confirm that they are healing properly. For these injuries, the distal radius and distal ulna fractures, a sugar tong splint is the preferred choice of splint, and patients, of course, should be educated also on RICE, the acronym RICE, or rest, ice, compress, and elevation, as this is the mainstay of treatment in all orthopedic injuries. Pain management, of course, should be addressed as well, and typically a short course of NSAIDs is sufficient. However, occasionally, of course, depending on how the severity of the injury and severity of pain, a 3-day or less PRN opioid prescription can be appropriate as well. So the general return to work or sports recommendation for these patients, those with sedentary jobs, they can return to work immediately. However, patients with physically labor-intensive work, they should not return until they have regained almost full function and strength of the affected wrist. And then for athletes, they too should return to sports when they have regained near their baseline strength as well. And once they do return to playing sports, they should be instructed to use a palmar splint for the first few weeks of activity and play, just for extra support for that wrist that was affected. So next up are metacarpal fractures or fractures of the hand. Typically, these type of injuries occur from direct trauma, but they may also occur from repetitive stress or overuse as well. So these fractures are classified based on their anatomy, and so a great reason, again, why understanding the basic anatomy and terminology is going to be very helpful for you in managing these patients. However, it of course does take a lot of practice and studying, so becoming more familiar with these topics outside of practice will make you feel a lot more confident when you're actually encountering these situations in real life. So the first digit that is identified as the thumb, second digit is the index, third is the middle, fourth is the ring finger, and then finally the fifth digit is the pinky finger. These are further divided then into head, neck, shaft, or base of the bone. And on the next slide, there is a really great diagram actually that labels those for you. But similar to the wrist fractures, metacarpal fractures often recover well using splinting and then following up with an orthopedic specialist. Significant swelling can occur with these extremity injuries due to the dependent positioning, and so a removable plaster or fiberglass splint is going to be the best option because this really allows for the swelling to occur. The Burkhalter splint, this is a great option for metacarpal fractures, and the directions for how this is applied is there on the slide. Most likely you will not be the one applying the splints on patients, as will be like the medical assistants doing those things, but it's really helpful to become familiar with which splints are indicated and with which injuries, especially when working obviously in the urgent care setting. Actually, at the end of this video too, there's a diagram from 3M that's really a real easy basic rundown of which splints are used and when. It's actually the table that we reference at my place of employment, and I make sure to share it at the end of this PowerPoint. Phalanx fractures, they are a very common occurrence in the outpatient setting as well. And so this slide gives you pretty much everything that you need to know when managing these. Many of these injuries heal fine with, of course, splinting and may not even require an orthopedic referral. Instead, they might be able to just follow up with their primary care providers. It kind of depends. So up to date, they give you specific indications for when an orthopedic referral is indicated. And it's in the following circumstances. So fractures that involve a joint, rotated or shortened phalanx fractures, comminuted or angulated fractures, spiral and oblique fractures, condylar fractures, and then large avulsion fractures, and finally fractures of the neck of the phalanx. So really that's a lot, and it'll take probably a little bit getting used to. I think always, again, err on the side of caution. So if you're not sure, I'd say just you should refer them to an orthopedic specialist. But when you get a little bit more familiar, then there are some other types of fractures that can just be safely managed in primary care. And then just for clarification purposes, condylar fractures, those are fractures, because I didn't know what that was, honestly, the first time I read it, so I think it helps to define it. Those are fractures that involve the joint surfaces of the phalanx, and those are most commonly seen in the proximal phalanx. And so that would be one of the circumstances where you would refer them to the orthopedic specialist. The splint of choice, it depends on where the fracture is located on the phalanx, and they are listed here for you. So for a proximal phalanx fracture, a radial or ulnar gutter splint is going to be the best option. And then for a middle phalanx fracture, that's when buddy taping to the adjacent finger or using even a finger-toed splint are going to be appropriate choices. And then finally, for a distal phalanx fracture, there's actually a DIP finger joint splint that's very easy to manufacture there in the office and is perfect for those type of injuries. And there, of course, are pictures there for you so you can kind of see how those are placed. All right, so before I begin discussing ankle and foot fractures, I want to briefly touch on the Ottawa ankle rules. If you are not familiar with this, then it's a wonderful tool, super easy to use and practice for guidance on who needs an x-ray of the ankle and or of the foot. So it reads as this: a series of ankle x-rays are required only if there is any pain in the malleolar zone and any of the following are present. So bone tenderness at the lateral malleolus, bone tenderness at the medial malleolus, or inability to bear weight both immediately after the injury and while on exam. And then a series of foot x-rays are required only if there is pain in the midfoot zone and any of the following are present. So bone tenderness at the base of the fifth metatarsal, or bone tenderness at the navicular bone, or inability to bear weight both immediately after the injury and on exam. So that's just really easy to follow and a great tool to use when examining your patient. In the red box, there gives a really good definition too of what is classified as being able to bear weight, and it's identified as by the patient who can successfully transfer weight 2 times to each foot, so a total of 4 steps. Even if a limp is present, these patients are still identified as being able to bear weight on the affected limb or joint, whatever it is that they have injured. There's also an image there of a normal AP ankle x-ray. As I've said multiple times, I think it's really helpful to look at those normal x-rays so you know when something is abnormal. Also, I highlighted the ankle mortise or mortise. I really honestly don't know how you say it, but in the next slide, I'll cover the importance of knowing the location of this. So similar to the other fractures, initial management is going to be rest, ice, compress with splinting, and then elevating for ankle fractures as well. So for distal tibia and fibular fractures, the best splint of choice for these injuries is going to be a short leg posterior splint. And this actually holds the ankle at a 90-degree angle. And patients should be instructed to remain non-weight bearing until they see an orthopedic specialist. And so it's going to be really important for you to consider this part when discharging your patient, whether or not it's going to be crutches or something else that you are getting for the patient so that they can remain non-weight bearing. There are criteria that make an ankle fracture quote unquote more stable or unstable. So fractures that are isolated to either the lateral, medial, or posterior malleolus, so only one fracture site present, then that indicates a more stable fracture. Fractures that are non-displaced, fractures that are not associated with a ligament injury as well, and then fractures that are below the level of the mortise. So remember, that was that highlighted portion in the previous slide, and it's defined as the hinge that connects the distal parts of the tibia and the fibula to the talus. So fractures that occur below the level of the mortise are defined as more stable fractures. So unstable ankle fractures, those often do require surgical repair, and an orthopedic consult for those patients should be done within 3 days of the initial evaluation. Finally, fractures of the foot, including fractures of both the metatarsals and then of the phalanx. So significant swelling again and ecchymosis are seen with these type of injuries, of course, because again, due to the dependent positioning of the foot. So it can be kind of alarming with the swelling and ecchymosis that does appear with these type of injuries. Minimally displaced or non-displaced fractures of the metatarsals that are, of course, neurovascularly intact can be properly treated with, you guessed it, rest, ice, compression, and elevation. So splinting options are listed there for you. The posterior short leg splint is actually a really great option for these injuries as well, in addition to the ankle fractures. The fifth metatarsal in particular, this is a common site for a foot fracture due to its positioning, and it actually makes it susceptible to also have stress fractures that can occur there. So for non-displaced proximal fifth metatarsal fractures, it's very specific, but these are one of the more common fractures that do occur of the foot. These can actually be splinted using soft compression bandaging, and then either a hard-soled shoe or even a walking boot that you can get commercially. When I was reading about it, they actually say that the commercially available walking boots are more comfortable and may even provide better support than the hard-soled shoe, so you can discuss that with your patient. And then x-rays should be repeated in about 1 week following the injury to confirm that the fracture does remain stable. But you might have to educate the patient that these can take months for a total recovery back to baseline. All right, so this is a slide here that I found on 3M's website, and it's their quick and easy guide to splinting. We have this actually up at the urgent care that I work at, and it's located in our procedure room, so it's a great reference that we all use whenever it's needed. Initially, I found myself honestly referring to this all the time with the orthopedic injuries that were coming in. Now I think I pretty much have this thing memorized, but I definitely wanted to share it with you as I think it's a really great tool and reference to have. But I think that is going to be it for today. Honestly, that felt like a lot of material to go over, and there's obviously so much more that we could discuss. Perhaps I'll make another part to this video, maybe like a little ortho series. I'll be honest, I had no idea, honestly, that I even enjoyed ortho until really like a few months ago when I started to get a better grasp on it. With all the ice and the snow recently, during winter, of course, orthopedic injuries have become like a really common chief complaint that I have been managing. And I don't know if I'm just so happy that it's something other than COVID or what, but I'm actually just really enjoying ortho lately and learning all about it. So let me know how you guys feel about it. What specialty, if not ortho, really interests you the most? I am interested to hear. Leave it in the comment section down below. And then of course, please don't forget to subscribe to the channel. It is a free way to show your support so I can continue making videos just like this one. Until next time, I wish you nothing but the very best. Make sure that you learn something new every day. And until next time, take care and I'll talk with you soon.